Good morning, everyone. First, let me thank Dr. Vijay Kumar Vada sir for conducting such a nice theme-oriented GI cancer, GI focus chapter 1 program. And today on day 2, we'll be discussing extensively on esophageal malignancies. So let me start with the first esophageal anatomy, a surgeon's perspective. Brief introduction into the embryology and development of the esophagus. Esophagus develops from primitive gut tube, which forms at around 18 days of the embryo. And at the end of first month, it divides into foregut, midgut, and hindgut. Esophagus develops from the foregut. And during development, the septations, basically the respiratory system and the foregut esophagus develop from a common foregut tube. The septations occurs at around 4 to 5 weeks, and incomplete septation can lead to tracheoesophageal fistula. The lengthening and canalization finish by week 5 to 8. Incomplete canalization and lengthening can lead to atresia, and muscular differentiation occurs by 8 to 12 weeks, and problem with differentiation can lead to motility disorder. Coming to adult esophagus anatomy, esophagus start at the inferior border of cricoid cartilage and end in G junction, extend from C6 to T11 vertebra. Length is around 22 to 28 centimeter, varies according to length, height of the person. In male, it is on an average 25 and female 23 centimeter. Basically, anatomically, it can be divided into cervical, thoracic, and abdominal esophagus. Functionally, it can be divided into upper esophageal sphincter, tubular esophagus, and lower esophageal sphincter. And surgically, it can be divided into cervical esophagus, proximal thoracic, distal thoracic, and abdominal esophagus. Endoscopic measurement are important because in clinical practice, we use the endoscopic measurement for all our decision making regarding esophageal resection. So all the measurements done from incisor teeth. The first landmark is cricopharyngeal constriction, and which is around 15 centimeter. Next is carina, which is around 25 centimeter, and next third is G junction, which is around 38 to 40 centimeter, depending on the male or female patients. Coming to cervical esophagus, length is around 5 centimeter, extend anteriorly from cricoid cartilage to suprasternal notch, and posteriorly from C6 to T1 to vertebra. The surrounding anteriorly surrounded by pretracheal fossa, which extends down to pericardium, posteriorly prevertebral fossa, which extends down to diaphragm, and the covering is loose fibroalveolar tissue. Arterial supply is by superior and inferior thyroid artery, left and right, and direct small branches from common carotid artery. And veins drained by inferior thyroid vein. However, the important thing to note is middle thyroid vein crosses over the esophagus here from thyroid to the internal jugular vein and needs special care during dissection. Innervation is from recurrent laryngeal nerves and sympathetic chain. The upper esophageal sphincter is a 2 to 4 centimeter high pressure zone between pharynx and cervical esophagus. It is formed by semicircular cricopharyngeal muscles, and it originates from cricoid cartilage, encircle esophagus like a sling, blend superiorly with oblique fibers and inferiorly by pharyngeal constrictor. The weak areas that is of surgeon's interest is the superiorly the Killian triangle and inferiorly the Lymer triangle, which are the point of diverticular formation. Then approach to cervical esophagus, as the cervical esophagus lies to the left of the midline, the approach is mostly from the left neck approach. However, rarely right neck approach can be performed in few cases like corrosive strictures where dilatation may be required before the definitive surgery. And here the vessel that needs ligation is the inferior thyroid vein. Special care needed during mobilization of the anterior layer because of the presence of membranous trachea. And anastomosis should be below cricopharyngeal muscle. Superior anastomosis lead to high risk of aspiration. And any leak or perforation in the cervical esophagus needs immediate drainage because of the risk of spread through the paraesophageal and retroesophageal space, causing mediastinitis. Recurrent laryngeal nerve, it origins from vagus. Right RLN recurs around the right subclavian artery, high up, and left RLN recurs around aortic arch, lower down. The ascent is in the tracheoesophageal groove. Left RLN lies closer to cervical esophagus because of the left deviation of the esophagus. The surgeon's concern here is there is risk of injury to specifically the left recurrent nodes. So fat in tracheoesophageal group should be sharply dissected from the esophageal wall and avoid use any metal retractor for the tracheal retraction. And injury is around seen in 1% of patients to left RLN, result in hoarseness, impaired mobility of cervical esophagus, and impaired cricopharyngeal muscle function, impaired swallowing. Both nerve injury can lead to vocal cord paralysis and tracheostomy. Coming to thoracic esophagus, length is around 20 centimeter, extend from thoracic inlet to diaphragmatic hiatus. Radiologically, it can be divided into upper thoracic, which extend from 20 to 25 centimeter, extend from suprasternal notch to azygous arch, mid thoracic 25 to 30 centimeter, azygous arch to inferior pulmonary vein, and lower thoracic is 30 to 40 centimeter, inferior pulmonary vein to LES. Upper and mid thoracic esophagus shift to right, so best approach through right thoracic approach. This is the topographic anatomy, just describing the position of various structures in relation to esophagus. This is the upper thoracic esophagus, and this is the lower thoracic esophagus, the position of various structures.